need technical assistance during your
Good afternoon, everyone, and welcome to the CDC's Hemoglobinopathy webinar series. I'm Mary Houlihan from the Division of Blood Disorders, and I'm going to be serving as today's moderator. So before we start the presentation, I would like to go over a few points. The conference will be in mute mode during the presentation, so when you want to ask a question, you will have to press *6 to individually unmute your line at that time. Since we can't see who wishes to make a comment, I will ask that you electronically raise your hand if you wish to speak. In order to do that, you'll need to click on the Q&A tab on the menu bar of your webinar screen. Once you're in the Q&A window, click on the hand icon in the upper right corner. This will display your name to us here on the CDC end. So I will be able to call on participants as their names are displayed. So you can raise your hand at any point during the presentation, but we're going to wait until the discussion period to address those comments. I also wanted to let you know that this session is being recorded. So today's topic is strategies to improve implementation of hydroxyurea, and our presenter is Dr. Courtney Thornburg. She is an associate professor at Duke University Medical Center and is the director of the Pediatric Sickle Cell Program and co-director of the Duke Cirrhosis Center. Conducts research to improve the care of children with bleeding disorders, thrombotic disorders, and sickle cell disease. Dr. Thornburg's research interests include risk-based therapies for children with blood disorders, pharmacogenetic strategies to improve safety of medicines used in children, and strategies to improve adherence to medication.
The conference is now in silent mode.
And now I'd like to turn the presentation over to our presenter. So Dr. Thornburg, if you could please press *6 to address the audience.
Hello, this is Courtney Thornburg, and I want to thank everyone for listening in and especially for the invitation to give the presentation today. I presume I can be heard at this point?
Yes, we can hear you loud and clear.
Great. So really the goal for the next 45 minutes to an hour is to discuss strategies to improve implementation of hydroxyurea next. And I'll first give just a brief overview of sickle cell disease and management of sickle cell disease, with then moving on to a real focus on hydroxyurea. We'll discuss barriers to hydroxyurea implementation, and then discuss ways to improve the implementation of hydroxyurea by looking at current guidelines and experience with hydroxyurea and talking about strategies to improve medication adherence. Next. So sickle hemoglobin, or hemoglobin S, is the primary hemoglobin in individuals with sickle cell disease. And in the oxygenated state, the sickle hemoglobin is free within the red blood cell, but in the deoxygenated state, the sickle hemoglobin forms long polymers, which then cause damage to the red cell and the characteristic shape change and decreased lifespan of the red blood cell. Next. And this leads to the various manifestations of sickle cell disease, primarily through the pathophysiology of hemolysis and vaso-occlusion. And the complications of sickle cell disease can be grouped into several categories: chronic anemia, including hemolysis, jaundice, cholelithiasis; acute complications, including pain, priapism, stroke, acute chest syndrome, and splenic sequestration; and chronic organ damage, which can affect the spleen, brain, kidneys, lung, bones, and eyes. Next. In terms of the management of sickle cell disease, this really depends on early identification of babies with sickle cell disease through universal newborn screening. And the first goal of this early identification is to educate the families about sickle cell, especially how to recognize the life-threatening complications of the condition. And then to focus on prevention and early treatment. Very important things are prophylactic penicillin, immunizations, and recognition of fever to prevent life-threatening blood infections, early treatment of pain, and screening tests such as transcranial Doppler ultrasound, which can identify those children who should receive regular transfusions to prevent stroke. In terms of the therapeutic interventions, we have a fairly short list. Transfusions can be used chronically to prevent complications such as stroke and are more commonly used for acute complications such as splenic sequestration and acute chest syndrome. And really, hydroxyurea is the only disease-modifying medication that we have at this point, and the remainder of the talk will focus on this medication. Stem cell transplantation is the only cure for sickle cell disease. It is very important to discuss, but is beyond the scope of today's topic. And then there really is becoming a fairly robust pipeline of new therapies for sickle cell that are still under investigation. Next. So with hydroxyurea, we really have now over 30 years of experience and research to go on when we're thinking about implementing the medication. And it was in the early 1980s when the proof of principle studies were done, which showed that hemoglobin F increased in individuals with sickle cell when they took hydroxyurea. And soon after that, there were phase 1 and 2 trials in adults, and then the landmark MSH study in adults, which showed decrease in acute complications. Subsequent to the MSH trial, there have been follow-up studies, including recent publication that hydroxyurea decreases mortality in adults taking hydroxyurea. Similarly, there have been studies in children to show the safety and efficacy of hydroxyurea, as well as long-term effectiveness. These have included early HUG kids and HUSOF studies, and then more recently the Baby HUG trial, which was a phase 3 randomized placebo-controlled study in infants starting between 9 to 18 months of age and continuing follow-up for 2 years to look at prevention of chronic organ damage as well as impact on acute complications. And even more recently, so the current studies are focusing on hydroxyurea as a means to prevent CNS complications. So overall, we really have a lot of data now to support implementation of hydroxyurea. And actually, Dr. Wong will be giving a presentation through this forum at the end of the year, so you can tune in to that. Next. In addition to the trials, there has been health services research to look at impact of hydroxyurea on cost. This is one example from Dr. Lanscron at Hopkins, which showed in adults who are taking hydroxyurea, those individuals who had the highest refill rates for hydroxyurea use had the lowest medical costs per month. Next. And really the ultimate goal with hydroxyurea or any therapy for sickle cell is improvement in the quality of life. And in the adult MSH study, hemoglobin F response was associated with improvement in health-related quality of life in those receiving hydroxyurea. And in a retrospective cohort study of children with sickle cell disease who had completed the PedsQL at our center at Duke or the Midwest Sickle Cell Center, the child and parent-reported physical health was positively associated with hydroxyurea use. But despite all these data, hydroxyurea is underutilized, and there have been several studies looking at reported use of hydroxyurea, and overall it seems to be about 10% in this published studies. Next. This was highlighted several years ago at the NIH Consensus Conference on Hydroxyurea, and the proceedings of that conference identified significant challenges to the implementation of hydroxyurea. And they noted barriers at the provider level, the patient level, including parental acceptance and medication adherence, and at the systems level, including access to care and insurance. And we'll spend more time talking about these. But first I wanted to highlight some provider-reported barriers that were noted on a survey conducted out of Medical College of Wisconsin when medical providers were asked about prescription of hydroxyurea. And there were several categories of concern. One being concern about patients actually taking the medication and following through with the necessary blood tests and follow-up. There's also concern about the patient's fear of side effects. There's concern that revolves around family planning in terms of contraception and male infertility, concern with potential for cancer risk, and then particularly in children, concern about lack of FDA approval, lack of formal guidelines in children, which we'll discuss, and then a very basic thing in terms of lack of time and resources that providers need to explain the risks and benefits of hydroxyurea to patients and their families. Next. And in the same survey, 26% of providers indicated that the rate of families declining hydroxyurea was greater than 20%. And they listed the following reasons why families declined. Again, the fear of cancer, fear of other side effects, not wanting to take a medication on a regular basis, not wanting to follow through with the laboratory monitoring, and just having the idea that it won't work. Next. And then in another study by Dr. Hayward, this was actually a patient-focused study, and there were questions to individuals who had previously taken hydroxyurea but had stopped, and questions to individuals who had not taken hydroxyurea. In those who had previously taken hydroxyurea, 39% said that they stopped because of a doctor's recommendation, and 35% said they didn't like the way it made them feel. And then in those who had not taken hydroxyurea, only 36% said that a doctor had previously suggested that they take hydroxyurea, so still a large proportion that weren't being offered the medication. And then a large percentage, 85%, who thought that it just wouldn't help. And so major things that were identified through this study were no perceived benefit, lack of knowledge, and concern for side effects. One, just the overall lack of information, as well as concern of birth deformities and cancer. And so now we'll start to talk about improving implementation of hydroxyurea, starting at the provider level, because that's the provider is the one that needs to initiate the conversation in most cases and to make the prescription. And so one thing that always helps is clearly delineated indications. And so we can get these from the FDA, we can get these from evidence-based guidelines, and we can get these from recommendations from investigators. And then once you have the indications and you have a proportion of the patient population that you want to treat, then you need to really know how to do this. And there are several references in the literature, including one in Blood on how I treat young children with hydroxyurea, and I'll talk about our experience at Duke to highlight the way that we have implemented hydroxyurea. So in terms of the FDA, the current FDA indications are for Hydroxyurea, and it's indicated to reduce the frequency of painful crises and to reduce the need for blood transfusions in adult patients with sickle cell anemia with recurrent moderate to severe painful crises, generally at least 3 during the preceding 12 months. So this goes along with what we saw in the MSH study, and it's really focused on adults and those with severe disease. In Europe, there's a 1,000 milligram breakable tablet that's approved for adults as well as children. And the European Network for Rare and Congenital Anemia has made recommendations for hydroxyurea to prevent recurrence of acute pain and acute chest syndrome, so as a secondary prevention. They have expanded recommendation for treatment of chronic severe anemia, specifically baseline hemoglobin of less than 6 to 7. So this is different than the FDA recommendation. And then, moving on to the available guidelines. So the NHLBI published the Management of Sickle Cell Disease in 2004, and in that publication, it stated hydroxyurea is a valuable adjunct in the treatment of severe sickle cell disease, although its clinical effectiveness for individuals with sickle cell disease has not been reported. Meanwhile, it must be used carefully with full appreciation of its toxicity and possible long-term adverse effects. So again, with adults and those with severe sickle cell disease. Next. And I mentioned the 2008 consensus conference, and those proceedings stated that there's strong evidence supports the efficacy of hydroxyurea in adults to decrease severe painful episodes, hospitalizations, number of blood transfusions, and acute chest syndrome. But they did expand into children, saying that although the evidence for efficacy of hydroxyurea treatment for children is not as strong, the emerging data are encouraging. The current data on the risks of both short and long-term harms are reassuring, and I think this is very important, the risks of hydroxyurea use in adults are acceptable compared to the risks of untreated sickle cell disease. And I think there's, we have to, be aware and be vigilant for side effects of hydroxyurea, but we have to put it into the context of the severity of sickle cell disease that really impacts a lot of individuals and has significant resource utilization. Next. And so now we're anticipating, hopefully in 2013, an updated management of sickle cell disease from NHLBI. And it's my understanding that there will be a chapter on hydroxyurea with evidence-based guidelines for both children and adults. And interestingly, I'm looking forward to seeing the recommendations for more preventive care, and particularly with based on results from the Baby Hug study. Next. In one of the most recent publications from Baby Hug, the authors said that due to the benefit of hydroxyurea in decreasing acute sickle cell-related complications, clinicians should consider shifting their practice to prescribe hydroxyurea therapy for all very young children with sickle cell anemia, rather than treating only those most severely affected. Next. And this is based on reductions in the acute complications of sickle cell, including acute chest syndrome, pain, dactylitis, and transfusion. And the data are not shown here, but this was shown to be the case in children who were symptomatic at the beginning of the study, as well as those who are asymptomatic. Next. And we're hoping that this and other data will lead to FDA labeling for hydroxyurea for children. Along with this would be an actual FDA-approved liquid formulation of hydroxyurea, which is really required for the youngest children with sickle cell. And we are participating in an NICHD-sponsored study, which is looking at pharmacokinetics of the liquid formulation of hydroxyurea in young children. Next. So once you have sort of a established set of guidelines, you can see how you can adapt that into your clinical practice. And then the next step is, how do you actually do this, or sort of a cookbook of how to provide hydroxyurea safely. And I mentioned Dr. Ware's article, How I Use Hydroxyurea to Treat Young Patients with Sickle Cell Anemia. And this has guidelines in terms of indications for hydroxyurea with a focus on rationale for early treatment, as well as how to dose and monitor it. Next. And now I'll talk about what we've done at Duke. And really, a lot of our initial clinical experience came from children participating in clinical trials. And this has ranged all the way from HuSoft. There's a toddler hydroxyurea study, Baby Hug, the Twitch and Switch studies, and then the most recent hydroxyurea PK study. And that has actually informed a lot of our clinical practice. Now, I've divided the clinical practice up into pre-Baby Hug and then post-Baby Hug. And so pre-Baby Hug, our primary indications were in children 5 and older, unless they were participating in a clinical trial, and those that were symptomatic. And when I came to Duke 8 years ago, the definition of symptomatic was quite broad, including dactylitis, pain, acute chest syndrome, conditional TCD, hypoxia, and parental request. And we've had parents come from South Carolina and Virginia to have their children started on hydroxyurea. Please go back. And I've continued that. And now post-Baby Hug, we've decreased the age down to 1 year of age, and still would offer to any child with sickle cell if they're symptomatic, including those with hemoglobin SC or hemoglobin S beta plus thalassemia. But really now we start to have a discussion with about hydroxyurea at a very young age for those children with SS and S beta 0 thalassemia, along with the other education. Next. And as we discuss this with families, we talk about the hematologic goals, including expected increase in hemoglobin, expected increase in the lifespan of the red cells as manifest by decrease in the retic, increase in size of the red cells, increase in the fetal hemoglobin, which will effectively reverse the effects of the sickle hemoglobin. We talk about changes in the blood smear, and I'll talk about this later on. It's one of our strategies for improving adherence. And we talk about then the goal of myelosuppression to a goal of 2 to 4. Next. And then we talk about the clinical goals in terms of decrease or prevention of symptoms, decrease in acute care visits. And I like to highlight this because sickle cell is very unpredictable. You never know when the fever is going to hit or the pain. And that with hydroxyurea, there often ends up being more frequent visits, but you can have predictable visits and then hopefully decrease some of the unpredictable acute care visits. We also talk about improvements in quality of life, and then really to have a goal of staying as healthy as possible until there is a better alternative, which we all hope for. And then it's very important to discuss potential or at least perceived side effects, and these are the ones I focus on, primarily nausea and GI upset, and we recommend that the dose is given in the evening if possible, because that seems to be better tolerated. Talk about potential for skin, nail, and hair changes. The discussion of impact on male fertility is an important one. I think it's an evolving one with need still for data in terms of comparison of fertility in males with sickle cell versus males with sickle cell on hydroxyurea, and the potential for reversibility when hydroxyurea is stopped. Especially in the teenage girls, we need to talk about potential impact on pregnancy, and the recommendation at this point that women who with sickle cell who are trying to get pregnant stop hydroxyurea. And for those girls who are menstruating, if they're not on birth control, then we do monitor their pregnancy tests. We also talk about infections in the context of the goal of myelosuppression. Actually, I try to reassure parents that we have not seen an increase in infections, and really we see a decrease in acute chest syndrome. And actually, in the baby hug study, the children in the placebo group had a higher rate of febrile events. And then we definitely have to address that cancer risk, because this, as you've seen, is a high concern. And the first thing I talk about is that most of the malignancy that's been associated with hydroxyurea is in a different patient population, in the polycythemia vera population, which is already at higher risk for malignancy. And there have been reports of higher rates of skin cancer with long-term use, but as far as I'm aware, this hasn't been quantitated in sickle cell, and then also has to be taken in context with all the other risks of sickle cell disease. Next. So this is just a snapshot from the patient handout for Hydroxyurea, which we typically don't give to patients, because just in reading it, it's fairly scary, but we do have this discussion. And then if you'll go to the next slide, I actually prefer to use this handout from St. Jude Children's Hospital, which is a booklet about hydroxyurea treatment, and you see the sad sickle cell before hydroxyurea and the happy one after hydroxyurea. And it has a nice discussion about hydroxyurea indications and side effects, and this can be downloaded from their website. Next. And then just in terms of the prescription, our practice differs somewhat from the FDA recommendations, but we typically start with 20 milligrams per kilo per day. We increase by 5 milligrams per kilo per dose every 8 to 12 weeks until maximum tolerated dose, which is essentially a maximum dose without toxicity. We provide enough prescription to last until the next visit. And we make this very clear to the patients. It's not like the penicillin refills where I give them a year's worth without a second thought. But when the patients are ready to start a hydroxyurea, they need to agree to the follow-up. And initially, we do monthly visits until MTD. On a monthly basis, we, in addition to the visit, give the CBC, diff, retic, chemistry, and then, when applicable, the beta-HCG, and then we monitor the fetal hemoglobin quarterly. And then once they're at MTD, we do quarterly visits with the CBC, diff, retic, and beta-HCG. Semi-annually, we'll check the chemistry and fetal hemoglobin. And then if we are dose escalating, then we tend to recheck the blood counts in 1 month. Next. And one of the important points that I talk to families about is that this is not an overnight fix. Unlike a pain medication or antibiotic, you're not going to see immediate results. And it's something that we need to give at least 6 months trial, but it can take longer to get the full effect. And in this slide, you see so the red cell indices and the blood smear picture going from pre-hydroxyurea across a course of 22 months. Where you see increase in hemoglobin, MCV, decrease in the ANC and reticulocyte count. And then in the blood smear, you see more red cells and decreased sickling, increased targets. Next. Another important thing for both the patients and the providers to be aware of is the variability in hydroxyurea response. And from Dr. Ware's How I Treat article, he said every child with sickle cell anemia who swallows the medication has increased percentage of fetal hemoglobin and other expected laboratory changes, although considerable variation is observed among individual patients. And I think this is important for providers who are new to prescribing hydroxyurea to know that some patients will need a dose of 20 milligrams per kilo or even less, and some will need up to 30 milligrams per kilo or on occasion even higher. And it's important for the patients to be aware, because then this highlights the need for the monitoring, not only for toxicity, but also to make sure we're getting the optimal effect. Next. And then, as we are monitoring, we're monitoring for hematologic, toxicity in terms of if there needs to be any holes in the dose. And there are different definitions of this in the FDA, in clinical practice, and in clinical trials. Some typical ones are a hemoglobin less than 7 with a low retic. So basically, if your hemoglobin is going down and your retic's going down, that is not what you want. Typically, a platelet count of less than 80 to 100 would be considered a toxicity and a reason to hold, and an ANC less than 1,000. And what we do if we notice this would be to hold the dose and then to recheck in 1 to 2 weeks and then to restart at the dose that was previously tolerated. However, if there's a known reason for toxicity, such as viral infection or if there's parvo infection, then we'll hold the dose, and then once there's recovery, then we may restart at the current dose. And then it is, in terms of knowing about implementing hydroxyurea, it's important to know the different formulations. And so, as I mentioned, in the youngest kids, we use the syrup in a 100 milligram per mil concentration, but this requires compounding, and this may not be covered by Medicaid. There's a generic formulation of hydroxyurea, which is in 500 milligram capsules, and then the Hydroxyurea, which is in 200, 300, and 400 milligram capsules. And one thing that seems to be a growing issue is actually having my patients, not only be able to find a pharmacy that has the hydroxyurea, but then more so now having it covered by Medicaid. And actually earlier this week, I contacted North Carolina Medicaid to see what they covered, and it's really based on the national drug codes. And so in order for the medication to be covered, the pharmacy has to use the formulation that has an approved number. And in the case of the syrup, typically one would use a powder for the compounding, but the powder is actually not covered by Medicaid, so the pharmacy has to use one of the approved capsules. So I think this is very important to keep in mind, and something that you can help patients out with in terms of finding the pharmacies that have the right formulations that will be covered by their insurance. Next. And although we in the young kids usually start with the syrup, the goal will be to go to the capsule formulation as this can ease accessibility. And so we do try to start having the kids learn how to swallow pills or capsules. And these are some recommendations from Medical College of Wisconsin, but basically practicing. And rather than practicing with the medication, you can practice with candy, which is even better, and starting with small things like cake sprinkles and then going all the way up through the different candies. Next. And there's different strategies, but first you may try to basically to have the child open their mouth, put the capsule on, and and then drink something. It may help to have something with some consistency or bubbles to help the child swallow it down. And if that doesn't work, you can try the opposite in terms of having the child drink something and then put the pill in to swallow it. And you can try this with the different size candies until you're successful with the actual hydroxyurea capsule. Next. And so now we've had sort of the indications and the providers and the patients have bought in, and we've started the hydroxyurea, but how do we maintain this? Next. And so these are two examples of counts from two of my teenage female patients who have been on hydroxyurea, and it's just a snapshot of some of their most recent counts. And the one on the left is a young lady who's about to graduate from high school, is going to have a scholarship and to one of a few colleges in North Carolina, wants to be a doctor, and has really been well adherent with her hydroxyurea. And if you start at the bottom, which is the earlier dates, you see a nice hemoglobin, lower tick, nice MCV, and you go up, and actually with the most recent count at the top, I was quite concerned about the trend with the hemoglobin and MCV going down and the retic going up. And actually in this case, I wasn't sure if it was related to a recent illness or if she was slipping with her hydroxyurea. She said she was taking it, but we elected to do closer follow-up on her. And then the one on the right is another young lady, and who had really had pretty good response with the excellent hemoglobin, MCV, lower tick, but had some more ups and downs. And really, when at the top values where her hemoglobin was 8.7, her tick was 569, and her MCV was low, I really was not happy. And it turned out this was when her grandmother, who's her primary caregiver, had been hospitalized and then in rehab and really had not been overseeing her care. And I was happy yesterday. I actually saw her in clinic, and her grandmother has been watching her take every dose, and her hemoglobin and all the other indices are going in the right direction. Next. And so really this medication is a big problem. It's not a new problem. In 1979, Haynes wrote that in an area where efficacious therapies exist or are being developed at a rapid rate, it's discouraging that one half of patients for whom appropriate therapy is prescribed fail to receive full benefit through inadequate adherence to treatment. Next. And Dan Ariely, who's a behavioral economist at Duke, has highlighted this for chronic illness and says that with asthma and other afflictions that require more preventative measures, forgetting to take your medication will exacerbate symptoms and eventually lead to greater consequences. But until this critical point, there is no definitive moment where a long-term preventative medication clearly needs to be taken. If you have an asthma attack, you can always pull out your inhaler. Similarly, with sickle cell, you can take pain medication or go to the hospital for other treatments. Next. And so I like to think about adherence in the context of the health belief model, which states that whether or not an individual will undertake a recommended health action depends on their perception of the susceptibility to the particular condition, the severity of the consequences of the condition, and then the health action's potential benefits. Next. In the context of hydroxyurea, the likelihood that someone will take hydroxyurea depends on whether or not they think, what they think of their sickle cell complications, their perceived benefits of hydroxyurea, and then mitigating barriers to hydroxyurea implementation. So in terms of categories of barriers to adherence, there can be a barrier to know what to do or why, and this is often related to low health literacy. So they may not understand the instructions or the reason for the medication or the relationship between the medicine and the illness, may not understand the expected duration of use. For hydroxyurea, this is indefinite use, again, until something better comes along. They may not know how to sort of organize giving the medication or where to get it and in what frequency. Next. And then there can be barriers to doing. So you may not even get the first prescription or not get regular refills or forget. There can be it can be cost prohibitive, as we've talked about. It can be a perception on both a patient and provider level of being a non-responder, and then either the actual or perceived adverse effects. And so because this is an issue, we need to know how to assess adherence. This can be done with biologic measures, patient reports, medication counts, pharmacy records, computerized medication dispensers, and measures of treatment outcome. Next. In sickle cell with hydroxyurea, in a provider survey, the most common measures were biologic measures, including fetal hemoglobin and MCV, and patient interviews. Pharmacy records were also used, but at a lower rate. Next. Although pharmacy records have been the primary use, or the primary measure in clinical research studies, and overall the reported rates with prescription refills has been around 60%. Next. So because of this issue, in our clinical practice, we really take a lot of time trying to tease out the adherence in clinic. And our first step is really to use questions in clinic. So we'll ask the child and the parent, what's the name of the medication, what does it do, what time of day do you take it, is there associated routine, who's responsible, and how many doses have you missed. And then we use these, the answers to these questions to make decisions about whether or not to dose escalate. If someone's really saying they're not taking the medication, then we need to focus on that rather than increasing the amount of the medication. And we'll use it to make decisions about how frequently the patients come back to clinic, and when we're really concerned, then we will call the pharmacy to find out about the refills. Next. So what can we do to improve adherence? Well, we really need a toolbox, a multimodal strategy that includes education for the families, reminders for prescription refills and for actually taking the medications, and strategies for attending the clinic visits. Next. And in terms of the education, for the content, it needs to include the reason for the medication, the duration of the medication, expected response, anticipated side effects, the monitoring, how to get the medication, and how to take it. And this can be presented either verbally, written, or video, or some combination of the three. And it needs to be simple, without jargon, and without too much information. And it may take several, clinic sessions or conversations before a family really, understands about hydroxyurea and knows enough to, to get a prescription. Next. And then one of the things that we use in the clinic is the blood smears, since we have these characteristic changes that go along with adherence to therapy. And we either take the children and parents into the microscope room to show them their slide in comparison to a child not on hydroxyurea and in comparison to a child with a really good effect, or we'll give them a handout which demonstrates the effect that we're looking for. Next. And we've also used the hydroxyurea scorecard. This is especially useful for the teenagers where they can track the response to hydroxyurea. And then, the reminders are very important. And this, again, is from Dan Arelli. And it says, as for reminding your son, you may not have a choice. No one wants to monitor glucose levels all day, and he may need reminders to do so. But the reminders can and should come from his environment, as well as from habits you and your son can create together. Rather than reminding him every few hours yourself, create a mechanism that will remind him automatically. Several doctors whom I've talked to told me that they recommend patients who need to take medications twice a day put it next to their toothbrush. If you need to take your medication more than twice a day, the toothbrush will not be enough. Fortunately, with hydroxyurea, it's only once a day. Next. So the question is, what regular activity can be tied to your son's medications? Can it be connected to meals or hobbies? Can you set an electronic reminder in his cell phone? And this is something that I've really tried to get patients to do lately because everybody is coming in with their cell phones and smartphones. And the next thing is even looking for an app that could be used to help with reminders. Next. And there's actually several apps for patients with hemophilia, probably at least 5 for tracking treatments, and one can be used for adherence. There is not one that I found for sickle cell, but there are some generic ones, such as one from Script Your Future. And I actually did find one app for sickle cell that is allows patients to identify sickle cell providers and pharmacies that are close by. Next. And actually there is a lot of work going on now through a HRSA-funded initiative. This is working to improve sickle cell health care, and this involves 15 sites that are working on projects to improve the diagnosis and management of sickle cell disease. Next. And are some examples from some of the sites. On the left is an example from a Tennessee group that's using reminders, personalized reminders for patients to remember to take their medication. On the right is something being used in California that's called the Glow Cap, and this can transmit wireless signals from the bottle then to your electronic device for reminders to take the medication and to get refills. And then at the bottom, Hopkins is using social media to help improve the care of people with sickle cell. Next. And then really, the last things are overcoming logistical barriers. So again, getting the prescriptions. So you can think of unique strategies to help the patients get their prescriptions. Get them mailed from a pharmacy. If they don't have a pharmacy close by that has the right formulation, seeing if the patient has a low-cost drug program or a 90-day supply, and then basically identifying the best, cheapest formulation that is available for your patient. And then in terms of the clinic visits, the frequency of the visits is a real big question. We tend to have fewer clinic visits overall compared to a lot of centers, but I think it's a matter of looking at your patient population and figuring out what works best in terms of prescribing the medication safely, getting the education in, but then not making the visits, a hurdle that can't be overcome. We use our outreach clinics, especially for patients on hydroxyurea, since they need the most frequent visits. And then in some cases, we may need to look for partnership for pediatrician, especially in locations where there aren't, sickle cell centers in close proximity. Next. And I recently learned of an NIH-funded study that Dr. Smith is conducting called Enhancing Use of Hydroxyurea in Sickle Cell Disease Using Patient Navigators. And this is a collaboration between Virginia Department of Health and academic medical centers. And the goal is to see if using patient navigators increases access to sickle cell specialty care, and then in turn increases hydroxyurea use. And my understanding is that as part of this, They're using a video that was developed in Florida that is really trying to, can be used to empower patients to ask physicians about hydroxyurea. In an initial pilot study of adult patients who viewed the video, they did say that they had new knowledge about hydroxyurea and plans to ask their physician about hydroxyurea. Next. So in conclusion, to improve implementation, we need focused strategies on both the provider and the patient level. For the provider, we need to continue to look at the evidence, have evidence-based guidelines, to educate providers who aren't as familiar with hydroxyurea, to have adherence strategies for providers, and as well as, if they involve electronic technologies, to have reimbursement for those technologies. And in the future, something that may help implementation is to have personalized dosing algorithms from pharmacokinetic and pharmacogenetic data. And then on the patient side, to use lots of time and strategies for education, to work with each individual family to figure out what barriers there are and how to overcome them, and to keep thinking about strategies for maintenance and ensuring adherence. Next. And I'll be happy to take any questions. Thank you very much.
Thank you so much, Dr. Thornburg. This is really, really wonderful. So we are now going to open the line for questions. I'll need to remind everyone to please unmute your phone by pressing *6 when you do have a question. You can raise your hand electronically so that your name will be called in the order received. And we only have this line scheduled for 1 hour, so that looks like we have about 9 minutes for questions, and I am going to need to end this session when we reach that time. So just as a reminder, if you do have a question, please try and make it brief and succinct, and get to the point of your question so that we have plenty of time for Dr. Thornburg to answer it. It doesn't look like we have anybody on the computer. If you don't want to type on the computer and you just want to press *6 and ask your question. Let's see. We do have one from someone with the last name Bolden. The question is, will we be able to have access to the slides? Yes. So the slides are all contained. The slide that you see up on the screen right now, scinfo.org, will have an archive of all of our webinars available. Yes, Suzette, we have a question from Suzette Oyuko. Is it possible to make the hydroxyurea scorecard, I think, available publicly?
I would certainly be happy to share it with anyone. If you want to email me, and I can think about ways to get it publicly. I know that Duke ER is going to have a new website with some education and different things, so we might be able to put it up there. But if you'd like it now, you can certainly email me at courtney.thornburg@duke.edu.
Great. Thank you so much. Anyone else that would like to ask a question? If you can't get to a computer, you're more than welcome to ask over the phone. Just press *6 so that we can hear you. Okay, I'll ask one more time. Great. Well, it sounds like you answered everyone's questions with your very thorough presentation, so thank you so much.
You're very welcome. Thanks again for the invitation.
Yeah, this was really, really wonderful. Thank you very much, and thank you everyone who joined in and listened. We had a lot of you on the phone today, so that's really wonderful. You can see on your screen our next webinar is on Thursday, April 25th. 2 to 3 p.m. Eastern, and that is Dr. Robert Yamashita. The title of that presentation, Building Behavioral and Social Science Databases for the Hemoglobinopathies, Lessons from the Study of Thalassemia. We hope that you will join in again next month, and we look forward to talking with you soon. Thank you so much. Bye-bye.
Bye.